Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. Premier Education brought to you at no cost, thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. I'm your host today, Eric Lim, and this week it's a great delight for me to present Professor Thomas Gaisl, an interventional pulmonologist from the University Hospital Zürich, to discuss the advances in robotic bronchoscopy. Thomas, over to you.
Hi, good morning, everyone. Thank you, Professor Lim, for the invitation. I'm here from Zurich, Switzerland, talking about advances in robotic bronchoscopy and talk about our robotic program in general, which has been running for more than a year now. So first of all, my conflicts of interests. I'm a proctor for robotic-assisted bronchoscopy in Europe and also a consultant for the players in this field. And mainly my academic research funding goes into this theme as well, as I'm a full-time IP for the whole week. So this is the hospital. I'm working here. It's the largest lung cancer program in Switzerland. We have 1,800 physicians and only 2 of them are IP doctors. So we're kind of hyper specialized where the doctors do what they do for the whole week. And we also have 2 thoracic surgeons, which started doing robotic bronchoscopy once we got the system. And what's also very important is we got 3 full-time nurses dedicated to bronchoscopy. They don't do anything else. And we also try to keep the anesthesia team the same during the week as well, which is also a crucial issue, which I'm going to talk about more later. So short history about our program. Our program has always been about ultra-thin bronchoscopes and cryobiopsies. We've always leaned towards these technologies in the past 5 years. However, we were always limited to, in the periphery, we were not consistently hitting our targets. So we always wanted to kind of explore navigational technologies. We first tried to give it a shot with the virtual navigation system, then also switched to electromagnetic navigation. And then we kind of ended up with the robotic program, which is also integrated with a cone beam here as well. Why am I saying this? This is basically we are considering, the robotic program as an adjunct tool to an IP program. And we are always very, very focused that our usual program, the conventional program with ultra-thin scopes and everything else stays the same and does not get cannibalized by, let's say, more expensive tools here as well. So what are the issues when hitting targets in the periphery for the lung? I always like to compartmentalize the problem into 3 columns. First of all is the navigation and the mechanics. We need something which can steer into the lung parenchyma, maybe also go through the bronchus and get into the parenchyma as well. So we need a robust and very strong tool which is able to steer in all 3 dimensions. We need something where we confirm ourselves in order to get rid of the CT2 body divergence. So we need spatial awareness of where we are right now. And we also need a good biopsy tool where we favor cryobiopsies, where we not just can grab something which is in front of us, but also be able to take kind of lateral biopsies when the lesion ends up to a lateral position of us. And so basically all of these columns, they are supported by randomized controlled trials where we know that cryobiopsies increase our diagnostic yield, especially in molecular pathology. We know that cone beams also increase our spatial awareness and have an effect on diagnostic yield. And last but not least, we're about to publish our randomized controlled trial where we show that robotic bronchoscopy with integrated cone beam also increases the diagnostic yield as well. I always consider this as a kind of house of cards because if one of these factors don't play out, the whole system collapses and we don't get our diagnostic biopsy. So you have to make sure that all of these things play along. So how does it work in real life? This is a demonstration of this technology in one case. So we had a 55-year-old teacher with a subsolid GGO in the periphery, which there was no hope of getting any REBIS signal out there. We knew that it was growing with a volume doubling time of under 500 days. So what did we do? In the first step, we did a diagnosis with a cryobiopsy, went out there with the catheter, made our tunnel in there. So with the robotic system, you can actually go into the periphery, pop through the airways, and then tunnel your way into the lung parenchyma in order to get your biopsy up there. Then place a fiducial in there. The fiducial looks from the inside like this. And in the meantime, while you are doing the robotic navigation, patient is lying sideways, and a thoracic surgeon can already start to prepare the patient. The lesion itself is then marked with ICG, which with the Da Vinci system is can be visualized as well. And then you can confirm also R0 in your wedge where the fiducial stays in there. And this is kind of a one-stop shop approach, which we reserve for patients which have a very high pretest probability in order to make sure we do not waste resources in there. But I think you can see the technology itself is really powerful and gets you into every corner of the lung and makes sure you can resect with a minimally invasive approach and a lung sparing approach, especially. So this is what a robotic bronchoscopy looks like from the inside. So in the beginning, it looks like every other robotic bronchoscopy where you go into segment 3 up there. You can also see that the catheter knows its shape, so it can overlay with a software tool and tell you where you are. At some point, 6 generations in, you can see that there's no continuing in there. So what we just saw now is the popping through the airway. So what we're doing now is basically we go through the airway here, and now we enter the lung parenchyma and go to the peripheral lesion where we think it ends up. Then we have another issue with the ventilation because now the patient is breathing and we have a 9mm lesion, and you can see that this 9mm lesion is like moving a lot. And during breath hold, we can minimize the movement here, but also get a clear picture with the cone beam CT. So this is how it works. Now we see that we do a spin with a cone beam, and now the integration comes into play where we actually mark the lesion and tell the robot where the lesion is. And this information, this spatial awareness is then sent over to the navigation system itself. And then you get rid of this CT to body divergence, which basically means that the calculated target was here, but the actual target was here. And now you can reposition and make sure you also hit the lesion where it actually is. And now you also see the next part is the cryobiopsy. You position your catheter well. You go to the distance to the pleura. You can measure that and make sure you hit the biopsy where the lesion is, and then send that to a fresh frozen in order to continue with your one-stop shop approach. So again, about 10% of our patients have this one-stop shop approach, whereas 90% of patients have a two-step approach. And that's obviously because only 60% of all peripheral lesions we hit are actually cancer, and about 10% of them are metastasized cancer from other organs as well. Last but not least, now you can see biopsy is finished. This is the fiducial from the inside in the canal we created in the lung to get to the periphery. And this fiducial now can be visualized using a C-arm during the VATS. I talked about this compartmentalization, which we use, which I think is also very important because you do not, you don't need the full setup for every patient. So depending on your peripheral lesions, you can also selectively employ a couple of tools which are only needed in selective cases. And basically because of this technology is extremely resource intensive and expensive, you can imagine that we try to limit the tools to what is needed. So I would say the full size package would be robotics and cone beam, where you need anesthesia. And this is usually reserved for lesions which do not have a bronchosign and do not have an REBA signal. However, if we have like lesions, large GGOs, we also can get in there with a conventional bronchoscopy and use the cone beam and only use sedation. So we do not necessarily need anesthesia for this. We can still intubate the patients as pulmonologists, but the patients are still breathing spontaneously. And now we do not need anesthesia, but we still can do a cone beam. On the other side, if we have a lesion where we get an REBA signal, but there's no bronchosign, we do not need to employ the cone beam because REBIS also perfectly confirms your tool in lesion as well. And of course, we also have the conventional option where we have a bronchosign and an REBIS signal. These are obviously cases where we do not use the robot because that would be just a waste of money. But the main thing here is that these technologies can act as standalone methods, and they don't always require a breath hold or an apnea. And now the very important part comes here as well, is that the robotic system can also be upgraded, or you can convert during the procedure from a conventional bronchoscopy to a robotic bronchoscopy, because the system itself does not necessarily need the planning. You can just go in and do your spin and the cone beam and do your robotic bronchoscopy spontaneously, and you can do your own picture as long as you know in which segment you go. This is just a demonstration of how accurate the system is if everything is employed. So this was an 8 mm solid lesion, which was confirmed as a tool in lesion with a cryobiopsy. And now in the histology, you can see the tumor margins in blue and also the cryobiopsy with some blood in the middle here as well. One of the reasons I'm showing this case here as well is that I think nicely demonstrates that we're not that far away from therapeutics here anymore. And depending on the tools you put in there, there will also probably be a way in the future to not just biopsy the lesion, but also get therapy in there. So what does this mean if you expand your program with a technology which can reach the peripheral airways without the need of a bronchosign? It basically extends your patient pool. These were usually patients we had to send away earlier. So 80 to 90% of these cases we now do with the robotics those are new cases, and which did not cannibalize our still running conventional program. We also increased our negative predictive value, which was also kind of a learning curve for our interdisciplinary tumor board, where we really had, where we really can base our clinical decisions based on a negative biopsy. And we also now have no limits in the lung, because obviously with this technology, once you enter the lung parenchyma and you can get to the periphery, you can basically access every corner of the lung and make sure that this is running. But the main thing I wanted to say here is that the conventional program still runs with the same numbers, and the robotic program is just is a kind of an adjunct tool to that. Why is this important? I think it's important because if you look at the literature, a lot of physicians in the US use the robotics for like really large lesions, where in Europe, a lot of people would not use robotic bronchoscopy for that. And that's why we end up with cohorts from the US, which have very large lesions hitting with the robotics, and our actual median lesion size in Zurich is 10 millimeters. And we do not get an REBA signal in most of these lesions, but still the diagnostic yield with this technology is totally irrespective of how difficult or advanced the case is. You just consistently hit with this technology in around, I would say, 90% of these cases. So in other words, once you're in a system with limited resources, we think it's only worthwhile to use robotics when it's really necessary. but also, keep using your ultra-thin program and your conventional skills to also hit lesions with a considerable less amount of money, I would say. So this is the reason why we think robotics, in Zurich at least, are mainly a tool for stage 1A lung cancer, nothing else. So we try to reserve this for stage 1A, where survival is the best, but still every millimeter counts here. Most of our lesions are in these stages, and the 17%, which are not in stage 1A at our center, are usually nodules, are 2 or 3 nodules in the same lobe or at the same site. So, and you can also see, similar to the screening programs, these nodules usually are next to the pleura, and 23% of them are also pure GGOs here as well. So is the technology really superior? In the beginning, we were kind of wary about this. We performed an RCT, randomizing to 2 IP doctors using ultra-thin scopes and lots of experience. And it turned out this was a huge game changer, because we only hit 14% of these targets, whereas robotics ended up hitting 89% of these. So due to ethical reasons, this group then also was offered robotic bronchoscopy, the conventional group. And after that, we hit 96% of the lesions. So in the end, it was actually probably even better for patients ending up in the conventional group here as well. And what's also very interesting is once your team learns to master the technology, the median procedure time does not take longer on a statistically significant level than conventional bronchoscopy. So that's why I think this is the future, especially for these small lesions without bronchosigns. When it comes to our historical data, so these are 600 procedures. All of them were performed by only 2 investigators using different navigational platforms. And you can also see that the virtual and electromagnetic navigation did not offer a similar breakthrough in terms of peripheral lesions. And that's also the reason why we did not end up scaling these technologies as well. On a side note, it's also interesting that, and this is especially true for electromagnetic navigation, the consumables or the procedural costs are basically the same as for robotics, albeit the capital costs are a bit larger for robotic bronchoscopy. When it comes to the learning curve, there's also a huge issue. It's basically a human factor where you start using 1 or 2 hours sometimes to hit 1 lesion. But as soon as you have more than 200 lesions in, you get to a plateau. You consistently hit lesions in the periphery, and you end up with a procedural time of about 20 to 30 minutes, which is also something where you can end up doing like 6 or 7 cases a day. What's also interesting is that if you do not have a lot of procedures, this learning curve will not get in and take place. This is, I think, very similar to what we already know from surgery. And for the patients, this is also an advantage, obviously, because X-ray dose and fluoroscopy time also goes down with this technology. On a meta level, here you can see all our lung cancer cases, which were diagnosed mostly at stage 4 within the past 6 or 7 years. And you can see that those are all cancer cases with all diagnostic modalities. And you can see that robotics actually enabled us to hit more lung cancer cases. And that was primarily due to an increase in earlier stages. That was stage 1A. Again, all diagnostic modalities across the whole center. And about 80% of these stage 1A cases were diagnosed with robotics in here, which was something we couldn't offer the patients before. What does this mean for the stages? So obviously before, and I also have to say here, we're unfortunately, we do not have a lung cancer screening program in Switzerland. So basically all that you see here is based on incidentals, where most of them were presented at stage 4 in the last 6 years. But now when you introduce robotics in this, you get to see that about 63% of the cancer diagnoses are actually end up in stage 1. So this kind of resembles of what we know from Nelson or other national lung cancer screening trials. Whether this also translate into a better survival is something we do not know yet. We're about to find out in the next 5 years. But what robotics certainly did is that it kind of flipped the whole script, and now we're mostly seeing patients at stage 1, whereas before we saw them mostly at stage 4. Last but not least, obviously the costs are a huge factor. When we calculate the whole program for about 8 years, we see that the capital costs only make about 3%, but most of the costs actually go into the consumables, which is also 22% of the case costs. So in other words, the consumables in these cases make up more than the materials for bronchoscopy, than physicians, than the administration, and the lab, including molecular pathology. So this is also something worth considering, that this is probably not something we can do on a long-term base. Obviously, I mean, there are significant downstream revenues for the hospital because these patients mostly can be operated. We also do a lot of more SBRTs, and we also expect that immunotherapy will probably go down, whereas obviously right now we're still seeing the same rate of stage 4 cancers. But if we continue that for a longer time, we're also kind of interested in what happens at the end of the stage 4s here as well. So already finished. For us, at least in Zurich, this technology represents kind of the first clinically significant advancement because it's best used in non-competitive lesions, which have a low pretest probability, where you can now minimally invasively get a diagnosis. And they're also ideal for non-competitive lesion where, surgery was the only alternative until now. But now you get a very elegant tool to tell you whether you have cancer or not. And the reason why we reserve this for these small lesions is that we do not cannibalize our own program. We now know that the RCTs confirm that this will probably play a huge role in stage 1A lung cancer. And what you can expect is kind of a 4-fold increase just when working with incidentals, which, by the way, is comparable to that what you expect from a screening program, which we're about to get in the next 2 years. And of course, the human factor is extremely important here. That's why I've kept saying, there are only 2 people working on this mostly, because the experience and routine makes you run the program more efficiently, so you can counter the economic pressure stemming from these robotic technology. So, and in the end, it's, I think, the kind of a best add-on to an existing IP program, especially if you have worked with navigation bronchoscopy before. And in the end, this is our team where we're working. Those are the 2 thoracic surgeons. And yeah, thanks a lot for your attention.
Excellent. Thank you so much for an excellent presentation, Thomas. I've got lots of questions, but it's really refreshing to see such a nice view about economic importance. Many of the interventional or robotic bronchoscopy talks, which I've attended to, always have a focus on biopsying everything inside the whole chest, and very few have a focus on, actually having a much more developed, considered approach to it. You've mentioned several zones, and you also mentioned the probable use of EBUS on its own without the need for robotic navigation.
Mm-hmm.
Can I ask one step further? Do you think there's any role for no localization for tumors that are on the actual surface of the lung? For example, for the surgical biopsies, it's relatively easy to localize. And
yes.
For me, I mean, I see 3 levels on this. If it's right on the surface, the surgeon can see and feel it. You can just staple it out, and it's very, very cost effective. Slightly deeper to that is a guide wire, which saves everybody operating time. And then the third level of depth for me is when all this starts kicking in. What are your thoughts to that?
So I couldn't agree more. I mean, if the lesion is on the surface, there's no need for bronchoscopy, given that there is a high pretest probability for cancer. This is something we regularly discuss in our lung nodule board. And if robotic bronchoscopy is not needed, including from the perspective of a surgeon, then we don't do it. Then the second thing, we did the guide wire as well, but we switched to the fiducial because of two things. First, you can it's kind of you can combine it with the fresh frozen, and second, you can also combine it with a two-step approach. Because the issue is, like in most of our patients have a pretest probability of about, I would say, 20 to 25% using Brock model, things like this. In reality, we're seeing 50 to 60% cancer, which also means that a lot of these patients do not be operated on. And a lot of people don't talk about these patients because they don't end up in these statistics. But a lot of young patients, for example, with solid or GGO lesions, do not need an operation. And with the robotic bronchoscopy, you can spare them from an invasive surgery. This is another issue. So I think the most important thing is here, where do you use these tools, in which cases? And I think the reality is that every hospital will have lots of nodules below a centimeter, which are not at the periphery of the lung. And this is, I think, where this technology shines.
Question from Dr. Ali, who's asking about the comparative methods for biopsy. Is cryo, when do you use cryo, and when would you consider a forceps biopsy?
So I would say we did a lot of RCTs on the cryobiopsy, and where we think it really, really stands out is the molecular pathology rate. So we can get like really large samples from that, where we can do a lot of it. And we kind of, forceps is not something we use anymore. We use it in super selective cases, but I would say 98% is cryo only. We also do not use the needle because we could not recreate the data from the US, where the needle was quite well received. So in most cases, I would say we use cryo only, get in and out, and are finished at 25 minutes.
Excellent. Question from Dr. Al Najjar, who's asking about complications associated with tunneling or going past the bronchus with regards to both pneumothorax and also bleeding rates.
Yeah, I mean, that's a good question. We got our way in, but we saw very early on that patients with robotic bronchoscopy, given that you have the intraprocedural imaging, have very low complication rates. So we're at 1.2% pneumothorax rate, and we had to use our blocker in 3 times in the last year in 500 procedures as well. So these are extremely precise biopsies with very low complication rates.
Question from the audience who is wanting to know how close are we to complete end-to-end robotic lung cancer diagnosis, i.e. presumably without the use of a operator during the interventional bronch itself?
Yeah, that's a question I get a lot, but I think, in my personal opinion, the steering of the catheter and the handling with the probe is probably the last thing I would give the robot authority over. So I really enjoy, the preciseness, where the stability of the catheter, and also the option to tunnel through the lung. But I would probably never give up the the sovereignty of the steering as well. I think that will be the last thing to give up.
It's interesting because, I mean, with autonomous steering cars, the safety and the margins and everything is so controlled. And for the autonomous driving cars, the level of danger is like massive. When I've been playing around in the exhibitions with the robotic bronchs, either using a track wheel mouse or like an Xbox controller,
Yeah.
tends to be much, much more simple though. I mean, presumably it's conceivable that if you encode that there's minimal force to go into where you want, but actually allow the computer to navigate to the endpoint, that would be a simple and safe method. You don't actually need a human to, to play the, video game of following the tunnel and going to the endpoint.
Yeah. I mean, yes, I think, and there's also a way where probably this will end up. Probably in the beginning, it will be assisted navigation, and then at some point, it will probably even be a fully autonomous navigation. But personally, I think this is really fun. I really enjoy it. It's like playing computer games with a real case scenario. And I mean, if it comes, I, I have to be convinced for Ford. But of course, obviously, there is a scenario where this works out, and maybe computers will take the biopsies in the future.
Yeah, because even for external CT biopsies, computers or robots are now being drawn into that field as well, being able to ascertain the external angles and direction of travel, presumably more than humans can do, or at least suggest a direct path to where
Yeah.
the lesion's going to be. Super
Yeah.
fascinating discussions, huh?
I would still argue there are lots of use cases where you do not go the conventional approach, especially when you have a lesion next to a large vessel. We tend to not go use to bronchus, which is attached to the vessel. We try to go to another way and then use the lung parenchyma to make a biopsy which is perpendicular to the vessel itself in order to save us from a blowout bleed. So it's not always this simple, but
Yeah.
yeah.
Definitely a super interesting space to watch. As always, there's too many questions
Mhm.
that we have time to answer. So thank you very much for your talk. We have this month is going to be Robotic Month. So next week is going to be Daniel O talking to us about advances in robotic surgery. I think a very hot topic at the moment. Which just leaves me to thank our sponsors, AstraZeneca, Medtronic, and Medela, the sites of care. Without their sponsorship, this couldn't have been brought to you. And last but not least, Thomas, once again, thank you so much for an excellent presentation.
Thank you for the invitation. Goodbye.
Goodbye.